of Harbin Medical University. My name is Li Jinqiang. I'm the moderator. And today we have so many experienced operators in this room. The first operator is Dr. Gong Tai. He's a superstar in our hospital. And the second and the third operators are Dr. Sun Danghui and Dr. Zhang Song. We also have Dr. Zhao Ji and some technicians and nurses to join us. And first, Dr. Zhao will introduce the case.
Good morning, everyone. I'm Zhao Ji from the first affiliated hospital of Harbin Medical University. Here, I will briefly introduce the basic information. This patient is a 63-year-old male who admitted to our hospital with a chief complaint of the paroxysmal chest pain for 3 months. His risk factors include hypertension, myocardial infarction, smoking, and alcohol drinking history. The echo check in our hospital shown the injection fraction value is 63% and the cardiac structure is normal. This is an essential ECG result. It is shown single rhythm with VPC. And the patient was suffered from acute myocardial infarction 3 months ago and received PCI at a local hospital. This is a previous angiography image. We can see the calcified lesion in left main and 80% stenosis in proximal to the middle LAD, with LAD fourth diagonal branch is a true bifurcation lesion and relative normal LCX, with 60% stenosis in OM and 17% stenosis in proximal to middle RCA, with severe calcification. After standard deployment in LAD, unsignificant slow flow was occurred, and the procedure had to be stopped due to the unstable hemodynamics. Patient is now bound for complex IVUS and or OCT-guided PCI of left main to LAD using RA and or shockwave IVL, and we will analyze the characteristics of the proximal lesion and evaluated the LAD stand expansion by the intravascular imaging. Considering the angina symptoms, we calculated the QFR, a novel non-invasive physiology assessment method invented by Chinese scientists, and the LAD is 0.58 and RCA is 0.93. So we could know the LAD cause physiology ischemia and could be treated. As we know, although they had some disadvantage of FFR, such as the pressure wear is difficult to manage, are relative long learning curve and limited by medicine for some patients. It is still the gold standard for physiology financial assessment. Just now, we had finished the FFR check. FFR for LAD is 0.59 and FFR for LCX is 0.95. So we can see the FFR is very close to the QFR value. Here, we also did the CTA in our hospital, and we can see the proximal LED image is his, and it is difficult to evaluate the plaque feature. Even the image had been magnification. In this situation, we are impossible to make a detailed PCI plan before the procedure, especially in some CTO cases. For these conditions, we seem to have nothing to do early, but now Professor Li Yue in our hospital had successfully invented an intelligent visualization system for the CT angiography, which not only could readily analyze the characteristic of the plaque with different color, but also could rotate the 3D coronary tree at any angle as you wish and could present any part you are interested in. Let's see the details.
Hello everyone, here is Wang Dingyu from the First Affiliated Hospital, Harbin Medical University. Now you can see the intelligent visualization system for coronary CT angiography, which is original invented by Professor Li Yue, just like the system we showed in the former cases. We can see the reconstructive view of aorta, coronary arteries, and their plaques based on the coronary CT angiography. In the system, we can rotate the arteries freely to identify the lines clearly. We can also move the arteries to the middle of the window. Okay, just like this. Now let's hide the aorta, the right coronary artery, and their plaques, both the calcified ones and the non-calcified ones. Okay, and now let's in. We can focus on the left coronary artery now. There is there is also severe stenosis in the proximal LAD, and we can see that the severe calcification is in the proximal LAD and also in the ostium of the LCX. Mm. Uh, Now let's rotate the model, and we can see there's almost 360-degree calcification. Now let's have the stent, has the non-calcified plaques and the LED lumen, the LCX lumen, and the distal calcification, and enlarge the calcification in the proximal LED and LCX. And now let's roll the calcification. We can see, yes, it's definitely 60-degree calcification, and is both as a ostium of LAD and LCX. Now it's your turn, Professor Lee.
Thank you. With the help from our AI system, we can see there was a severe calcified lesion with circled around the left main and proximal LAD. That provides us a warning that maybe we need to modify the proximal lesion with some special devices, and maybe we need a guiding catheter with more strong backup support, and so on. Those information will not be afforded by either CTA or coronary angiography alone. Please show us the angiography this time.
So can you show us the angiography this time?
Angio.
All right.
We can see at the end of our left main, there are significant calcification. Nearly 80% to 90% stenosis in the medial LAD to the proximal LAD. Nearly 70% stenosis and severe calcification in the medial RCA to the proximal RCA. Nearly 50% stenosis in the proximal LCS. And that's all. Thank you.
All right, thank you so much for the introduction. Dr. Gong, I think we got a very complex case. It's a left mean bifurcation lesion with a lot of calcification, and the circumflex looks kind of normal from the angiography. And there's mild to moderate stenosis in RSA, but the functional assessment was negative. But this patient was stented before in the middle of RD. So right now, based on the patient's information, what's your initial strategy?
Okay, firstly, for this case, we will perform an intravascular imaging with an IVUS and OCT integrated imaging system to evaluate the proximal LAD lesion, especially the optical calcification lesion. And then, based on the lesion, the imaging result, we will choose appropriate pre-treatment and stenting strategy and technique.
Yeah, for this kind of lesion, the imaging test is super important. But both IVUS and OCT, they have their pros and cons. But right now we have integrated imaging system. I think this is a genius idea. It was invented by Chinese company. So with this system, we can make full use of their strength and countering their limitations. So I think Dr. Johnson will interpret the imaging results of the integrated imaging system for us. Dr. Johnson?
Okay. That's my pleasure. So here I would introduce an excellent device.
Yeah, I can hear you.
Okay, that invented by our domestic scientist, the IVUS and OCT integrate imaging system. So like the common IVI catheter, it was delivered to the distal reference settle, and the maneuvers procedure is similar with OCT. And there would present both IVUS and OCT image on the screen. Moreover, the two images were already calibration by the AI system, and we can simultaneously analyze one plaque morphology by two methods. So this would complete their own disadvantages, such as the lower resolution of the IVUS and the lower penetration of the OCT. So here, at the Professor Gong side, we show the size of prior stent expansion. As we know, stent under expansion is most consistent factors of stent thrombosis and restenosis. Here, after identify the reference vessel segment, we had access MSA in LAD is 5.11 square millimeter hours, distal less than 2 millimeter distance had no over 16-degree dissection. So we know the previous stent had got the optimization results. Accompanying with the catheter backwards, we calculated the MO in LAD as 2.09 square millimeter as we seen. Because of the eccentric fibrolipid plaque, significant shadowing and attenuate. They had over 216-degree vessel profile invisible, and the plaque burden is about 79%. So the IVI image shows a diffuse lesion in proximal to middle LAD, and the total length is about 34 millimeter, or over 34 millimeter. So the also LAD error is 4.28 square millimeter. Black burden is about 74%. We can see the cross-section view. here had a calcium field lesion over 118 degree from 2 to 9 o'clock. So I think the osteo LAD may be not an ideal stent location.
Well, thank you. I leave this question to Dr. Gong. Because Dr. Gong, after the use of imaging test, now we have a better understanding of the anatomy of this lesion. So what's your next step?
Yes, according to the result of the imaging, we decide to choose the intravascular laser tripsy to pre-treat the calcification lesion at the ostium of LID to get full stent expansion and opposition. And next, we will implant two stents from the middle segment of LID to the left main with provisional stent.
All right. All right. So for this lesion, I think you prefer to use the one stent, right? It's crossover.
Yes, a crossover strategy, and but this patient have long lesion, and this may be need to middle segment of LID to the left main body.
All right. Because from the imaging results, we can see there's some stenosis in the proximal or circumflex. So, Dr. Zhang, why not choose that strategy?
Okay, so here we can see the image, IVL image of the LCX. We can see the distal reference lumen diameter of the LCX is 3.1 millimeter. Also, area of LCX is about 3.39 square millimeter in OCT and 4.11 square millimeter by hours. As we see, the FFR for LCX is 0.95. In summary, I think gel wire technique is a rational choice for the LCX protection. And as Professor Gong said, we will use crossover technique to treat the LM-LAD lesion. According to the definition criteria proposed by Professor Chen Shaoliang in China. We know the lesion in side branch is longer. This patient's LCX lesion is longer than 10 millimeter. But the stenosis diameter is less than 70%. So we think this is a simple bifurcation lesion, and it depends on the results of definition theories trials. The provisional stent strategy is rational.
Yeah, I think you are right. Because the provisional stenting is the preferred strategy. So right now, Dr. Gong is trying to pass the IVL catheter through the lesion, right?
Yes, now we use a 3.5 IVL balloon to pre-treat the calcification lesion.
Mm-hmm. So now you give the pressure to 4.
Yes, 4 ATM, and then we are inflated to 6 ATM.
Uh-huh. So after maybe 10 seconds,
Yes.
you increase the pressure to 6.
Yes.
All right. Let's see how the IVL works on this lesion. So Dr. Zhao, Dr. Gong will take the one stent strategy because he shared with us he wants to go with the crossover technique. So is there any other strategies that can treat this lesion?
Yes, of course. If standing must be performed, there are several techniques. Techniques that can be used for minor 010 lesions. May branch, then the portion may thus increase the risk of the restenosis of the main branch and sand branch. Another technique is stand kiss balloon technique. In this technique, a stand is located in the ostium of the main branch main branch with a balloon inside branch inflated to the relatively low pressure. The main branch stand is pulled back against the inflated balloon. The stand is then deployed, and then balloon removed thereafter. Double technique can also be used.
Yeah, actually, there are so many techniques that could be used to treat the lesion like this one. So Dr. Gong, you have finished the IVL, right?
Just complete 3 circle.
Mm-hmm. So,
Uh,
sometimes, when we try to use IVL to correct the calcification, we have to do it a few times, right? It's not just a one-time thing.
Yeah. ML should be performed,
Mhm.
and I think it will help us to get optimal lens deployment.
Mhm. For the treatments of calcification, except for IVL, maybe there's some other techniques like rotational atherectomy or some dedicated balloons. So for this patient, you prefer to use IVL. So I think after the IVL, we have to run the imaging test, right, to see the results.
Okay. So as the IVI shown, there is some superficial and some deep calcified lesion in LED. So we choose the IVL shockwave balloon to modify the LED calcified lesion. So IVL has been recently introduced as a novel technique with potential to safely modify calcified and optimize stent expansion. So this pressure wave are able to selectively break both superficial and deep calcium within the vessel wall, backbreaking macro fractures in the calcified plaque. Vessel compliance is increased, and IVL thereby facilitate adequate balloon and stent expansion. So vessel trauma is soft tissue is minimized as the sonic pressure wave pass through the non-calcified tissue as a result of minimal differences in density.
Yeah, compare with the RA, the IVL is very safe, and the risk of the no flow is very, very low.
Oh, of course, inherent to its concept, calcium fragments remain in still after IVL treatment, so potentially reducing the occurrence of slow flow or no reflow.
All right, let's see how the IVL works.
Yes, the balloon is inflated at pressure of 4 atm initially, and then impulse of mechanical energy delivered to the calcified lesion at a frequency of 1 Hz. So this energy interacts with the atherosclerotic plaque, causes vibration that cracks and fractures the calcified columns in the superficial and the deeper layers.
So now we finished the IVL, right?
Yes, and we will recheck the intravascular imaging to evaluate the results of our pre-treatment.
All right. Dr. Zhang, do you know right now there's any criteria for the results after IVL? Like what kind of result is acceptable? I know after the use of IVL, at this point, we can deliver stents. Right now, is there any criteria for that?
Yes. Hold on. Let's we together see the IVI image. Maybe you could find some interesting things.
Mm-hmm. The integrated imaging system is very good because it's much better than OCT alone or IVUS alone. But the thing is, when we use the integrated imaging system, we also have to inject contrast, just like OCT.
Yes,
Yeah.
that's basic mechanism is similar with OCT.
Yeah.
We could also to injection the contrast to flush the blood.
Mm-hmm. But this idea is very genius, I think.
Yes.
It's one pullback, yeah, 2 images, IVUS and OCT.
in one screen.
Fantastic.
Yes. The best advantages of this integrated system is it can complete each other disadvantages.
Mhm.
Today,
Great, fantastic. Two kinds of images. So Dr. Zhang, you will interpret this image for us?
Of course, it's my pleasure. We can see the imaging quality as well. And here we can see from the 9 to 12 o'clock, there had some cracks of the calcium film lesion.
Mhm.
And in addition, more importantly, the previous some under expansion stent have been improved significantly.
Mhm. So after the use of IVL, actually, we could see some cracks on the calcification.
Yes,
Yeah.
we can see from the cross-section view, like the 6 to 9 o'clock.
Dr. Gong, do you think right now the result is okay, or with no need for more IVL? We just maybe treat it again with some balloons, right?
yes, we will modify the leading further using NC balloon
Mm-hmm.
and the 3.0 NC balloon to get further modification for the calcification leading. And then we will deploy full stent next.
Okay. So we have to try our best to make the lumen as big as possible. And it'll be very easy to deliver stents.
So there is a way to assign whether we could choose whether to use further modify after IVL. When we use some post-dilated balloon to treat the calcific lesion, we could see from the angiography if there had a waste sign, waste sign of the balloon. So if there is obvious waste sign, that means we should need more IVL or we should more modify the calcific lesion after that.
This is a very good way to tell whether IVL effect, is has worked or not.
Yes. And now Professor Gong has used a C balloon to treat it.
I think the balloon can be very easily expanded.
Yes.
That means the IVL really worked.
From that, since we could know the IVL results is very good.
Dr. Zhang, right now there's another problem. Maybe after the pre-treatment with this lesion, we had to put stents. But the thing is, the stent has to be put from area diameter. There's a clear discrepancy between left mean and RAD. So for this kind of situation, how do you usually choose the stent size?
Oh, yes. There has two questions about the stent lining zone. The first one is, as we know, we have to choose the stent size and identify the stent lines. So commonly, due to the osteo lesion or proximal stent location site with larger side branch entry case, we often cannot be accurately identify the proximal reference lumen diameter. So in our hospital, we usually depends on the distal reference external elastic membrane to choose the closely downsized stent. And for the stent distance, we could calculate the distance between the proximal reference with the distal reference at the longitudinal view or the cross-sectional view, which would avoid a geographic maze. So for this case, there had a significant discrepancy aside between the left main and the proximal LED. So in this situation, we often choose the stent size depends on a set branch that cause inevitable mismatch. We often dilated the proximal stent by NC balloon 1-to-1 ratio with the proximal main vessel size. So with our experience, Professor Gong is preferred to choose to consider region of the inherent feature of the different stent platform, such as the chrome numbers, cell area, and choose a stent which has the best expansibility to deployment in the proximal LED to left main.
Give me a little contrast. Correct. Check the flow. Okay. Very
So-
excellent.
Dr. Gong, what are you up to?
The stent.
Mhm. So after the pre-treatment, the result is okay. So right now is the time to put the stents, right?
Yes. And according to the intravascular imaging result, the first stent, we will choose one 3.5 diameter. Okay, the first stent for the spectral branch, we will
Okay,
protect it
Student.
by use a little balloon. With a small
Yeah, okay.
balloon.
Mm-hmm.
Balloon.
Because the septal branch is kind of big. That's why we had to protect it
Yes,
before we put the first stent.
before the first stent deployment,
Mm-hmm.
a small balloon will be pushed into the sand branch. Okay.
No, actually, there's a little bit controversy about the protection of the septal branch because it's a septal branch,
Yeah.
right? Even though it's occluded, it doesn't cause any big ischemia. Maybe some doctors think, it's all right. I don't have to protect this septal branch. What do you think, Dr. Zhang?
The septal branch.
Yeah,
That branch is now.
but for this patient, the septal branch is kind of big. That's why Dr. Gong, put a balloon to protect it.
Of course, yes. So for the left main lesion, bifurcation left main lesion, the rule number one of the PCI is to identify whether is it a true bifurcation lesion.
Mm-hmm.
According to the Medina classification, this patient is according to is a Medina O 011 subtype.
Okay.
So for this patient, the Dr. Gong has already and we based on two rules for this LCX protection strategy. The number one is FFR value. The FFR value show us the LCX is 0.95, and another factors another reason is the IVL image. We also see the ostium area of LCX and the black burden both tell us just through a gelled balloon technique is enough to protect it.
Mm-hmm. So let's see how the stent is going to be expanded well.
Yes, here for this case is Dr. Gong used a small balloon to protect the spattle side branch.
Mm-hmm.
That because the spattle branch lungs is maybe I guess maybe about 15 over 60 millimeters.
Mm-hmm. Kind of
Yes.
long.
Yes. And this is the first bigger
LED.
So Dr. Gong, the first stent could be well expanded.
Yes, and the next stent will deploy. Okay, the second stent. Can you give me the second stent?
Mm-hmm. So what's the size of the second stent?
4.0.
Uh-huh. Because the second stance will be extended to the left mean, so
Yes.
it should be big.
From the proximal segment to the left main body.
Mm-hmm. You know, as we see from the angel, there's obvious discrepancy between left knee and the proximal RED. You know, I think after the second stance deployment, maybe we had to do some port technique, you know, to get the optimal result. What do you think of Dr. Zhao? Maybe after the second stance, do we have to do the pot?
Yeah, of course.
Just like a KPI involves the just like port. How should it be formed routinely after main branches standing? The port may correct the malposition of the stent in the proximal main branch, prevents under strut pausing of the subsequent vires, provides strut portion into the sand branch and open the struts in the sand branch ostomer. So it is easy to wire and balloon to pass into the sand branch. The port can avoid wire is exchanged outside the proximal part of the main branch. A salt large NC balloon set to the proximal main branch at least 6 or 8 millimeter in length. The distal marker of this balloon, NC balloon, must be positioned in front of the planar and the proximal marker inside the proximal standing segment.
So I think the second stand was also well expanded, right, Dr. Gong?
Yeah. Next step, we'll recheck the intravascular imaging and to evaluate the stent expansion, and if we will look at if there is malposition.
All right. Let's see the imaging test. Dr. Zhang, you know, after the imaging, we may know if we have to further, you know, optimize the stance. But the thing is, if we had to do the plot, so any of you can share with me, you know, any tips, tricks we can take, you know, when we perform the plot?
The port NC balloon size is should be very short. The size is selected by the stent by the stent size.
So both the size and the length of the balloon is very important for the part.
Yes.
Now we'll use the integrated imaging system again to see what is going on after stenting.
And just ready for the imaging.
Ready.
You ready? Yeah.
So what do you think?
So let's see from the automatic pullback view. So there's very excellent opposition. And there have maybe some distance from the center struts between the left main vessel wall.
Mm-hmm.
So we need AC balloon to post dilated the left main stent.
Yeah, there's a little bit malposition. I think, from the IVUS image, it's more clear than OCT, right?
NC
You could
balloon.
see the malposition from the IVUS image.
No,
compared with
no.
OCT.
No, because of the high resolution. So the OCT could clearly tell us
Mhm.
about the malposition. Because the stratus, stent stratus cannot be clearly displayed by the IVUS, but it's very clearly by the OCT.
Mhm. Okay, I'm just
And we
based on
can,
right now the image.
yes, now we are measurement of the MSA of the stent. The MSA is 4 point. The MSA in the left main is 80.78 square millimeter. It's very large.
Mhm.
So what is MLA in LAD? In LAD, so that is the advantages of the integrated system.
Mhm.
Just based on the IVUS check, we could not tell us so much information.
Okay, after perform the pulse technique, next step we'll revise the circle flex and then to perform heating balloon technique.
So this procedure is necessary after plots. You do this routinely in your practice.
This is a very interesting question. Different operators maybe have different choice,
Mhm.
but the routine heating balloon technique maybe provide good clinical outcome.
Mhm. So what do you think of this question, Dr. Zhao? After the pots, do we have to do the KBI routinely, or it really depends on the situation?
KBI involves the inflation of two non-competent balloons. One is in the main branch, just like LAD, and the other is in the sand branch, LCS, whose proximal parts are lined in the proximal main branch, just like in the left main. The aim out of the procedure after LM to the LAD standing is to remove the stand struts at the sand branch, just like LCX outterm, to eliminate the stenosis of the sand branch and maintain the cranial in its central position. Moreover, minimal balloon overlap is recommended to prevent stand deformation and overextension. KBI in the main branch and the side branch after the crossover technique of provisional stand does not improve clinical outcomes. So routine KPI is not recommended for a single stent technique. But in some cases, situation, just like the flow in the LCX is very slow. Just like there is a severe diagnosis in the sand branch, we will perform a KPI in order to restore the normal flow to the myocardial.
Yeah, you know what? For this patient, I think the pod is super important because after the pod, I think it's kind of easy to deliver a wear through the ostium of the circumflex. Right, Dr. Gong?
Yes,
I think because I saw it was kind of easy to deliver the wear in the circumflex.
The pod will help us to deliver the Y to the circumflex easily.
Mm-hmm. So what's the balloon size in the circumflex?
Easy balloon.
Mm-hmm.
I will 18 balloon to perform kissing balloon technique. AC balloon should have no significant injury of the ostium of the circumflex.
So we can see from the kiss balloon technique about the Dr. Gong. There is the little tips. Dr. Gong just tried to deliver the AC balloon to the LCX distal, but it's hard to across the stent cell. So he firstly used a relative smaller NC balloon to the LED proximal, and he will post-dilatate the NC balloon at first, and then try to deliver the NC balloon to the LCX distal. That would significantly enhancement of the pushability of the NC balloon. Yes.
So first we use this small balloon to dilate the distress cell, and then after that, if this distress cell is large enough, we can deliver the balloon we want.
Yes. And just know the operator has help us measurements of the MSA in LED, and it shows the MSA in LED is over 5.5 square millimeter by the OCT. It's a relatively larger MSA. So I think the middle to distal LED stent had got the optimization results.
Because right now, Dr. Gung is trying to dilate, all the parts of the stents in the LED. Maybe he wants to have a better results.
Yes.
Next, we will choose the 4.0 and 2.5 AC balloon to perform AC balloon technique. Okay, give me a 4.0 AC balloon. 4.0. Another 2.5 AC balloon. This is
4.0
yes.
NC 不弄
So recent consensus document categorizes the large treatable IVL dissection at lateral extension over 16 degree and longitudinal extension over 2 millimeters or involvement of Middle and advanced lasers, especially at the distal stage, should be treatment. But in our case, there is no obviously
Very
end-edge
good.
dissection.
Yeah.
The balloons are engaged already.
Yeah, 14. Yeah. Go. The imaging. Okay. 2.5.
2.5 in the circumflex.
Yes.
4.0 in the left mean.
Yeah.
You know, when we do the KPI, we cannot give the pressure too high, right?
Yes. Even a lower pressure with about 8 to 12 ATM.
Mm-hmm. Just to make sure the stents can be well expanded and it doesn't cause any other complications.
Yeah.
That'd be good enough.
For this patient, we can use a modified kissing balloon technique.
Mm-hmm. So tell us more about that.
The sand branch in the balloon should be inflated firstly,
Mm-hmm.
and then deflated to 4 ATM, and then in the main branch, the NC balloon should be inflated with a short overlap.
Mm-hmm.
And deflated immediately.
Mm-hmm.
Okay, now we just complete the KBT, that is kissing balloon technique.
Mm-hmm.
Okay, we will recheck the intravascular image and to get the optimal stent deployment.
All right, we'll run the integrated imaging system again
Yes,
to see the final results.
yeah.
So Dr. Gong, can you tell me what's the advantage of modified KBI? You know, just the very short overlap, that's it?
Modified KBI will less lead to the deformation of the stent in the left main.
Mm-hmm.
Okay, let's. For conventional KBI, should lead the deformation of the left main distal portion.
Mm-hmm. So with the conventional KBI, the stent could be deformed.
Yeah.
But with the modified approach, it should be well protected.
Yeah.
The risk of deformity is not that high.
Yes. Can you get? We will show a final angiography. It's very excellent.
Mm-hmm. Yeah, from the angel, it looks very good.
Yes. Okay.
And let's check with the imaging.
Yes.